and I will be the facilitator afternoon session. It's been a while since we met, and we're very excited to be back and connecting with you on network. And we look forward to a very exciting session today. And so today we will have in the house, in the hub, UTH team, and that's going to help us through with this session today. And so we have Mr. Chileshe here, who will be doing a presentation. And then we have Ms. Mukumbi, who also help us through a presentation. And so we are going to have a TA findings presentation, and then we will have a SmartCare demonstration, and then we'll have a clinical demonstration, both in completing the clinical forms as well as the pharmacy dispensation tools. These are some of the things that during the technical assistance and the visits that we have conducted in the facilities selected across the country, some of the common findings and challenges that we have experienced in a pediatric area. And so the main title for this particular session is Pediatric AIT Optimization. And we feel some of these interventions are going to help us improve pediatric care and optimize therapy on children with HIV who are under care right now. So we have on the panel, we'll have Dr. Thomas is on the call, Dr. Mia will be on the call, and a few other colleagues that we'll be able to identify as we go on, just to help us discuss this afternoon. Remember, we just want to remind you a few etiquette regarding echo. Each time you join in, kindly mute yourself. And if you have to turn on your video, make sure in a very in a place where you don't have any distraction, and so that it disrupts the event. And if you've got something to say, please go to the raise your hand icon, and then you can raise your hand, and then we'll be able to call on you. But maximize use of the chat, where you can ask your questions and your concerns. We've also put a link there for registration. We wanted to know who is on the call and who is with us today. So thank you very much. You are all welcome to this particular session, and we hope you will learn one or two things that will help us move the pediatric agenda, HIV agenda forward. So that having been said, allow me to ask the presenter here next to me to just introduce themselves. We'll start with at the far end. Maybe you could just introduce yourself to the network. Ms. Mukumbi.
Okay, good afternoon, everyone. My name is Mukumbi Kabesha. I'm a pharmacist working here at the Children's Hospital.
And my name's Chileshe Machiluka. I'm a clinician here at PCOE.
Thank you so much, Mr. Chileshe. I hope you're ready for us today.
Yes.
I think, please, you can go ahead.
Okay. Thank you, Dr. Koza. So thank you to everyone that has joined us today. So we'll be quickly running through the TA findings for the CDC supported sites. So on our objectives on this session, we'll share the findings of the TA in the 4 CDC supported sites, which are Lusaka, Eastern Province, Southern Province, as well as Western Province. Then to add on, we'll also do a SmartCare demonstration to prescribe how correctly doses are supposed to be done in SmartCare, as well as dispensation. Then lastly, we'll also demonstrate how to input in the pharmacy form in SmartCare, which will be done by Ms. Mukumbi. So the roles that UTH have been mandated, one is I've already mentioned in the provinces that you can see above there, Lusaka, Western Province, Southern, and Eastern Province. So our main roles, the focus is on the whole entire cascade of care, which is number 1, HDS, number 2, clinical, number 3, laboratory, number 4, pharmacy, then lastly, adolescents. So going to the objectives that UTH has. So to summarize, number 1, under case finding, the TA team ensures that HIV routine testing, completion of family testing, testing in pregnant and breastfeeding women. We also ensure that 80% of 2-month-old EID coverage and screening for tuberculosis in those children. Then number 2, for treatment, to ensure at least 98% of newly diagnosed HIV positive clients are newly initiated on ART, and all TB and HIV co-infected persons are also put on ART. Then number 3, on retention, to ensure family-centered DSD, which is differentiated service delivery, appointment systems are in place, as well as MMD for children that are eligible, which could be the 6 MMD or 3 MMD. Then number 4, viral load suppression, to ensure that 99% of viral load coverage and suppression as well. Then on ART optimization, 3 weeks ago, if not 4 weeks ago, we had a discussion over PDTG, and it's been introduced. I'm sure most of the sites have now received it. Then we need to ensure that children that are less than 4 weeks old and above 3 kg are put on DTG, as well as TPT for children. Then undertaken co-assistance, which we'll go in details to discuss. Then number 7, linkage to OVC services to ensure at least 90% of children living with HIV in high volume facilities are also screened for OVC eligibility. So on this slide, we'll start with HDS. So the team that was going around in these different provinces had all these common findings, which we'll discuss right now. So the first row of column we can see are the gaps, the second are the action points. Then lastly, that's the column for people that are responsible to tackle or implement all these changes. So number 1, the gaps that we found was poor usage of the HIV screening tool, which was a very common thing which we found in other facilities. Number 2, there was no space for HDS, as well as testing procedures were not properly followed. So among the recommendations that were put, number 1 is that we need to deploy the current screening tool, as well as registers that are missing in all these facilities need to be provided. Then recommendation number 2 is that all sites need to have or allocate a separate HTS room. We've seen that sometimes there's registry, as well as in the same registry, people are being screened for HIV, which doesn't guarantee any privacy or confidentiality. Then number 3, we've seen that there's also a gap in entering HTS results in SmartCare. So this is an action point that most of the sites should also embark on. Then the other recommendation was provide training in proficiency testing, as well as quality control to all uncertified testers. As we all know, only counselors that are examined are supposed to undergo testing. Anyone who's uncertified are not supposed to do any testing in any facility. Then lastly, provide continuous mentorship and supervise testing as per standard testing guidelines. So the responsible parties for this should be facility in charges, PHO, as well as DHO mentors, as well as the TA partners, which are UTH and other partners we find in different facilities and different provinces. So moving on to gap number 3. So the gap number 3 was inability to reach all contacts elicited due to local challenges. It may not be the same in all the facilities, but commonly what we had found is transport challenges. So number 1 among the action points, elicitation of all contacts and intimate partner violence should be done during the pre-test counseling. So we need to ensure that all contacts during pre-test are elicited and written down even before we can proceed further. Then number 2, we need to strengthen the transport system for index testing. So responsible parties are still facility in charges, the counselors as well, to ensure that elicitation is done properly. Ideally, it should be 1 to 3 or maybe perhaps 1 to 4. Then district mentors as well to provide ongoing mentorship as well as supervision to ensure things are properly being done. Then number 4, the challenge on number 4 was not all clients are offered intimate partner violence screening. As we all know right now, before the close of year last year, 2020, all partners were mandated to reorient or orient on safe and ethical index testing. So by now, I'm sure all the facilities had already completed all this. So among other recommendations, which I've already mentioned, that reorientation of safe and ethical index testing should be done. If this hasn't been done, then it should be a mandate that all counselors should start practicing safe and ethical index testing. Then point number 2 was provide index testing in all positive clients. This would also include clients that are linked to the facility, and screening for IPV should be done and monitor adverse events. So responsible parties are still the ART in charges, district mentors, as well as PHO mentors. Then moving on to number 5, we've seen a very low yield as well as coverage when it comes to know your child status, which is a gap which has been noted in all the facilities. So action points that have been agreed upon and what we can recommend right now in all the facilities, that number 1, the M&E needs to work hand in hand with the healthcare workers as well as CBVs. So their role, number 1, is to identify all women who have children and who haven't completed index testing yet. That's number 1. Then number 2, there is need to create a database or a database in Excel for the female TX current, which is 15 to 49. They need to choose a focal person or a champion to create an entry point where all this data would be captured, then submitted to M&E on a daily basis. So when all this triaging has been done, the recipients of care that haven't completed index testing, then the DAP personnel or other counselors or other implementing partners that are doing community testing should follow up all the mothers with children that haven't been tested yet. So the responsible parties, again, are facility ART in charges, which are the main people to trickle down information as well as supervise. Others are the PHO mentors as well as district mentors, including the counselors that will continue eliciting and following up people in the facility. Then others that we noticed is that most facilities also don't have a separate register for KYCS. They still use the same register as the index testing register. So it's recommended that facilities that don't have should lobby that a separate register should be provided. If so, they're using the same register. In the comments, they can improvise on a separate register. If it's the same, then they can put in the comment section to say this is a KYC, so that those indicators are documented separately and followed up adequately. Then coming to the 6th one, the 6th gap is test kits stockouts or shortages due to poor stock management. So recommendations are the HDS managers or counselors that are manning HDS should always be vigilant to do early reports in collaboration with the lab, that they should have adequate stocks and avoid running out. So early ordering is very important so as not to have any stockouts. So moving on to the next slide. So on ART services, the number 1 gap which was noticed in all the facilities, number 1, infection prevention measures were not properly followed, including the COVID guidelines as well as general IPC guidelines. So facility in charges should be very vigilant to ensure that everything has been adhered, including the environmental health technologists. Then number 2, we haven't seen any equipments in some facilities to capture vitals. Simple equipments like thermometers, BP machines, pediatric cuffs, even in some facilities, weight scales are not even there. But these children are being managed on a daily basis. So we recommend that partners as well as facility in charges should continue to lobby for all these things for proper management of our children. Then number 3, adherence forms in SmartCare are not properly filled in by providers. And we've noticed that short visit forms are frequently used in almost all the facilities. I think the general feel here is that children are supposed to be seen quickly so that you finish up the queues. But for quality care, we recommend that clinical forms are supposed to be used on all the visits, especially on children, because there are some things that are missing in the short visit forms. Then adherence forms as well. The key thing to ART management is adherence, especially with caregivers as well as children. So if adherence forms do not appear in SmartCare, this means healthcare providers are not even offering adherence forms to our children. So facility in charges as well as clinicians should be very vigilant to ensure that clinical follow-up forms are used and adherence forms are seen in SmartCare. Then number 3, when it comes to retention, another attributing factor is phone numbers are not collected on each visit, as well as home addresses are not updated. So on this one, we recommend that locator forms on a daily basis on each visit are supposed to be updated in SmartCare. If we're using files in some facilities that are e-last, maps should be properly drawn, household details, all the details should be captured adequately, as well as phone numbers on a daily basis. So facility in charges and counselors as well should be vigilant on this matter. Then coming to point number 5, late disclosure as well as delayed disclosure. Facilities are urged to start the disclosure process as indicated in the National HIV Guidelines. So we can all refer to page number 72 and table 25 in the February 2020 edition. Just ensure that you check that your guidelines are written February 2020 edition, because some of them do not have this table. So disclosure process should be followed properly. By the time these children are over maybe 10 years or 11 years or so, most of them should have been disclosed by then, but you can still refer to the guidelines that are available there. Then point number 6 is high viral load registers are not updated, and most of them in these facilities, those registers are handled by CBVs. So task shifting is a very common thing in these facilities where we just leave most of the work to the CBVs. But then if CBVs are overloaded with work 1, they may not even go into the community to conduct index testing and other tasks given to them. Then we may also notice that work is not properly done in those registers as well. Then number 2 is that EAC forms, on the same EAC forms are not attached in the recipients of care files. Then the EAC folders, there are also no EAC folders or EAC2s in the patient's files. So the recommendations that we had was, number 1, there is need to have adequate management of enhanced adherence counseling, which will include exploration of barriers. Number 2, taking proper ARV history as well as usage of the EAC Plan 2. And sessions are supposed to be recorded duly, and documentations and outcomes on documentations are supposed to be recorded as well. Number 2, facilities are supposed to appoint high viral load champions to ensure or quickly communicate if a high viral load result has been seen in a child so that EAC can begin quickly. Number 3, there is need to divide and assign all unsuppressed high viral load clients to specific trained healthcare personnel to conduct EAC sessions. So I'll stress on that point again, that only, if not available in any case, only trained healthcare workers are supposed to conduct EAC because they have the know-how on the drug history, dispensations, how it's supposed to be given, etc. And not leaving all the work to the CBVs that may be no less. But in facilities that we know CBVs are capable, we may continue to allow them under supervision. Then number 4 recommendation is that utilization of the EAC tool should be done and it should be documented duly. Then we also encourage DOTS services. It can be peer-to-peer, a healthcare worker to be implemented. Then the last point is OVC linkage for unsuppressed clients. Most of these provinces that we're visiting, OVC partners are there so they can be engaged for these clients that are on high viral loads. Then the last point on the gaps, number 7, is no dosing charts have been displayed or seen in most of the facilities. The recommendation to the district mentors and PHO mentors, as well as other healthcare workers in these facilities, that provision of updated dosing charts or posters or reference materials are supposed to be made available and used as well. So moving on to the third cascade, which is HIV care and treatment. So a few notable things that have been seen here is, number 1, the general feel is that there is knowledge gap in pediatric management in all the facilities. So what's needed here is PHO, as well as other partners, TA partners, to organize a training in pediatric ART management, as well as SmartCare. Then capacity building as well through mentorship should always be done through regular visits to these different sites to ensure that facilities are implementing. Then number 2, recipients of care do not come with drugs. So it's a practice at UTH that all the children are supposed to come with drugs at the facility. So number 1, this ensures and reinforces adherence. So we find out exactly how they're taking the medicine, at what time, how many tablets, then they show us the type of bottle which they're taking. Then number 2, this also ensures quality control between the clinician and the pharmacy as well. So all of us need to be on the same page. What clinician has dispensed should be what pharmacy has given out. What the patient has should be what the pharmacy had dispensed on the last visit. So we encourage that all the facilities should practice this same thing that UTH does here. Then number 3, we've noted that we've seen a lot of wrong prescriptions, as well as wrong dosage in according to weight band, and wrong prescriptions on SmartCare as well, according to the actual dose that is supposed to be given. So the recommendation on this one is that in some sites that we went to, we did some on-spot mentorship on pediatric prescriptions as well as dispensation, but then there's also need that the PHO, DHO mentors should continue supervising and reorienting on how properly they're supposed to be prescribed and dispensed in SmartCare. Then number 2, reorientation on the usage of multi-regimen prescriptions in SmartCare, which we'll demonstrate later on with Ms. Mukumbi. Then number 4, we've seen that there's been a low TPT uptake in children. We're doing well with adults, but unfortunately with children, there's been a lot of challenge there. So recommendations are that we need reorientation of TPT in children. Secondly, there needs to appoint TPT champions in all the sites. Then number 3, it could be optional in some facilities, but then there's also need that quality improvement projects can start on TPT to see how greatly we can improve in that area. So facility in charges, ART in charges, PHO, DHO mentors should partner together to ensure that all this has been implemented together. Then the last point on HIV care and treatment is incorrect dilution of AZT3TC, which we use for prophylaxis in highly exposed infants, especially at MCH. So an example we can give is that most facilities or MCH facilities still use the old guidelines, mixing 60 tablets in 10 tablets in 60 ml of water. So that's an old practice, which even now some facilities are still doing. So there's need that reorientation is done, and MCH coordinators need to be very vigilant to supervise and ensure that correct dilutions are being done. So moving on to the lab. So on the lab, gap number 1, which was noticed, is there's lack of trained personnel managing the lab. We can refer to task shifting. We found some CBVs manning some labs, some cleaners as well. We found EHT in the lab. So there's need that MOH as well as PHO and DHO to come in so that they deploy qualified staff to be manning lab. Then number 2 is unqualified staff doing phlebotomy or collecting blood samples, task shifting as well. We've seen it. Maybe lab personnel has gone somewhere, CBV is busy collecting lab samples. Then number 3, we also noticed that reagent stock out, which was a common thing in other facilities. Then the action points that we had noted down was number 1, deployment of qualified staff, which I had already mentioned. Number 2, there is need for training and reorientation to all healthcare workers on DBS collection, packaging, as well as storage. Then number 2, there's needs to follow up with reports and requisition with ZAMSA to ensure that all the reports have been received so that facilities can receive adequate stock later. Then We also recommend that facilities should always get in touch with each other. There's need to strengthen communication to find out whether other facilities are overstocked with some reagents so that they can borrow and reuse. Then responsible people, of course, should be PHO, DHO, as well as MOH to help us with all these recommendations. And facility in charges too should be vigilant in all these matters. Then number 4, there is lack of basic equipment in all the facilities. Then number 5, we've also seen that non-viral load samples are being wasted, especially with the hubs. So there's a tendency that communication will not be done on time, that biochemistry machines or CD4 machines will be down, but then other facilities will continue sending blood samples to that particular hub. In the end, all those biochemistries and other samples aside from viral load will continue being wasting. And we've seen this is a tendency in most of the facilities. So there is need, number 1, to strengthen communication between the labs and the hubs to avoid sample wasting. So the lab managers, facility in charges should be vigilant to always find out whether there's machine breakdown, whether they should continue collecting these other samples to avoid wasting. Then number 2, procurement of basic machines such as FBC, biochemistry, urine dipsticks, as well as point of care for DBS, which PHO, DHO, and MOH can definitely take up and provide feedback. Then number 6, there is inadequate space in most facilities, which is a big challenge. So a prefab can be considered for limited spaces in all these facilities, which the district can follow up and take it up. Then number 7, there's unacceptable equipment downtime. Then we've also seen delayed turnaround time for viral load as well as AID results. So recommendations are as follows. Number 1, we need to put in place a tracking system for viral load samples sent to the lab, as well as those that we're receiving. If there are any samples that haven't come through, there's need that lab managers to follow up on all those missing samples. Then number 2, there's need for early reporting of equipment downtime. Then lab managers also need to adhere to the scheduled maintenance of machines. Then the last point is there's need to use district mentors to follow up and retrieve all PCR results as well as viral load results that are pending. Okay. So moving on to pharmacy. So just like the lab, pharmacy as well, we've seen a lot of unqualified staff dispensing drugs. We've seen them correctly dispense maybe TLD or TLE, but perhaps that's very straightforward. But with children who are on BD doses, we need a trained healthcare provider to dispense all these drugs, as well as provide proper counseling to the recipient of care receiving these drugs. So there's need to deploy qualified staff for this, which DHO, PHO, MOH, and facility in charges needs to take up. Number 2, there is knowledge gap in dispensation in SmartCare for pediatric formulation, which Ms. Mukumbi will demonstrate later on. Then number 3, there's lack of reference materials such as dosing charts as well as guidelines. So provision of dosing charts needs to be, provision of updated dosing charts needs to be given and supplied to facilities that don't have. Then number 4, lack of pediatric formulations. So specifically, we've seen that cotrimoxazole suspension has been an issue in all the facilities. So there's need that this commodity should be outsourced immediately for prophylaxis of children that are less than 5 years old. Then number 5, we've seen suboptimal temperature for drugs due to lack of, or rather non-functional air conditioners. So air conditioners in all the pharmacies are supposed to be turned on all the time at a correct temperature. Then there's need to also service them or report if there is machine breakdown to avoid wastage of drugs. Then number 6, temperature charts are supposed to be updated on a regular basis as well. So moving on to the last cascade of care, which are adolescent activities, before I hand over to Dr. Kozia. So number one, on adolescent activities, most facilities have no adolescents or caregiver support groups, which there's need to form all these groups for adolescents. So facility in charges, adolescent focal persons are supposed to create these support groups in the facilities immediately. Then number two, some support groups have mixed positive and negative adolescents, making it difficult for positive adolescents to share their challenges and experiences with each other. So in the view of stigma attached to HIV, it is important that all negative and positive adolescents are separated. All of them need to be free to share their experiences, especially the positive ones, the challenges, as well as other emotional comforts and moral support. Then there's also need to offer advice and tips to help one another, as well as cope with the situation of being HIV positive, which an HIV negative adolescent may not be in the capacity to provide to an HIV positive adolescent. So facility ART in charges need to find a way of separating these two groups. Adolescent focal person may also be necessary to identify what groups are, which ones, then they should be separated. Then number three, most facilities have no trained peer educators who do not even conduct on-spot counseling for their adolescents. So recommendation is that there is need for training to all the adolescents that meet the criteria for training. Then number four, most of the groups have no financial support, making it difficult to travel to other facilities to participate in adolescent activities, or rather even host local workshops at their facilities. So there's need for some support for these meetings for the adolescents. And number five, most of the facilities don't even have adequate space for adolescent support groups. Most of them will just sit outside in other areas, but there is need for a safe space in these facilities to be created for adolescents to be free and to discuss their issues and challenges and support each other. Then the last point on adolescent activity is we have lack of materials to use during support group meetings, and there is need that educator materials should be supplied. So facility ART in charges, adolescent focal persons, as well as DHO to take up this issue, as well as follow up adequately for adolescents. So this is where I end, and I'll hand over to Dr. Kozia.
Thank you so much, Chileshe. That was very informative, and I'm sure the network are quite informed about your visits to some of these facilities across the provinces. So thank you very much. I would like to just quickly, briefly open up for any clarifications or any further additions that the panel might have. I know Dr. Thomas, Dr. Mia might be on the call here. If there are any additions that they would like to make over these findings, the gaps identified, and some of the suggested challenges, suggested actions that can be done, and those that are responsible picking it up. So you can just raise your hand if you can, just to clarify a few thoughts. I've seen a comment from Dr. Zimba wants to find out about cotrimoxazole syrup. I think why Zamsa hasn't sent it around. I think we'll just try and hear that from, I think we'll check with the pharmacy team and might be able to assist us with that detail. And then Dr. Bosco wants to find out, has made a comment, suboptimal screening of advanced HIV disease among children should be included in the list of above gaps. I think certainly that's an important one, Dr. Bosco. Thank you very much. Any comments from the network? Any feedback regarding this finding? Okay, so if there is none, then we can move on to the next section of this presentation. And Dr. Zimba, you've raised your hand. Please go ahead and unmute yourself.
Thank you, Dr. Ziambo, and thank you for that presentation. Quite interesting gaps that have been highlighted. But to me, what worries me is I think we conducted a lot of trainings and we are still having gap in the care. I don't know what innovative ways can come across from this meeting that can help us address this gap, because even mentorship can only be provided quarterly, but the 3 months that you are away, the gap is still there. So how can we do it better? That's just my question and my thought, trying to think out loud.
Thank you so much, Dr. Zimba. Very, very important questions. So I'll open that up to the rest of the network. How do you think we can help close that gap? Mentorships, trainings, I think quite a few provinces have had those done, but we're still having those gaps. Any comments? I've seen a hand from Maureen. Please go ahead and mute yourself and make a comment.
Hello, good afternoon. Thank you for the presentation. For me, it's just the issue of task shifting. This is a big issue which we need to look at, and would like to hear any suggestions from the network. I think we've left a lot of HIV services to the treatment supporters. Thank you.
So another very important issue has been raised here, the issue of task shifting. I know that we are actually constrained when it comes to human resource, and one of the innovative ways has been to shift tasks to help and meet that human resource demand. And but how do we do that, ensuring that we continue to maintain care? So these are the good thing about this platform. It's a platform for everyone to just give in their thoughts, give in their ideas, share best practices, then we learn from each other. And so I want to encourage the network, please, if you have got a comment and you want to make an addition, please go right ahead, raise your hand, and then you can just give your comment to that. So any comments before we move on to the next matter? Dr. Zimba has raised a concern, and then we have Maureen who has raised another concern. Maybe we can hear from some of our senior colleagues on the call.
Yes, Dr. Ziambo.
Hello.
Good afternoon.
Afternoon, thank you. Dr. Muya, how are you, sir?
Fine, thanks. How are you?
All right.
Yeah, so regarding Dr. Zimba's question, I think what is important, I think, for us is, first of all, there has to be a mind shift from members of staff, that when there's an even orientation at the facility, after somebody has been trained and they're oriented on how to manage children, that also should be taken as a knowledge transfer. One was trained to the staff at the facility. This should be followed by continuous mentorship, because we also noticed that when you discuss with them, if you ask a question, have you been trained? They will say no. But if you go further to find out if they have been oriented on what to do regarding the management, you find actually they have been. So this question is something that we really need to ask properly when it comes to training. But I think the best I can say is that continuous mentorship is what is required. So we already have mentors who should have a program. There are mentors attached to each facility, such that if it's properly done, I think this gap can be met, where healthcare workers are monitored continuously, given to ensure that there's change in terms of the practice that they are doing. The challenge you have observed is that even when they are mentors, you go down there to see what's going on. It's like there's nothing happening in some facilities. So I think even as mentors, we should also change our way we do things. We monitor and ensure that there's a difference from where we started. If I start today, I should see that there's a change in terms of how people are practicing. That would be very helpful. And then on task shifting as well, what some of the observations we've made actually, it's just the attitude of us health, like, I mean, when I say health workers, those of us that have been trained, like nurses, CEOs, in some facilities you find actually, the feeling is that the one responsible for this job is, for example, a partner, for example. They would rather let this thing be done by a partner, because some of those people that are employed as community CBVs are under partner support, so that the ones they would want to give those tasks, because the feeling is that this job is supposed to be done by the partner, not by us health workers who are employed by Ministry of Health. I think also this attitude has to change. This is what we have observed, in addition to what Chileshe has said. So we really have to change our mindset that this is our program and these are our people that we are managing. Then you will see things change and change for the better. Thank you. Over.
Thank you so much, Dr. Muya. We appreciate those important comments. I will ask Michael from Mehari, and then Rose Chira will make a comment.
Good afternoon, Network. So just on the task shifting, like the doc was just saying, I think we have given much of our services to the community health workers, either be counselors and everything. You'd find that in the most of our facilities, maybe in Lusaka or so, even just the DBS, for example, the samples are being collected by the volunteers, both for NAT or the actual DBS. Very few of our nurses and clinical officers are able to do that. But you know, these are skills which are not trained maybe in school, but we meet them while we are in the service together with these same CBVs we are task shifting to. So instead of us being a resource to them, the CBVs now are being a resource to us. They're being the champions to us. So it's a warning which I want to give to our friends, us the nurses and clinical officers. Something which is not done, you know, us we believe in skills. If you're not hands-on, the skill goes. So let's take keen interest. There's nothing wrong even with us learning from these same volunteers who have been doing it for a longer time. Let's learn and own it. Most of these CBVs are there because of partners, but the moment the partner pulls out all the CBVs, then the services suffer at the facility. It also goes to most of our facilities. You find that the DBS at birth is not being done. For as long as the counselor is not there, either over the weekend or in the night, then the DBSs won't be done until when the counselor is there. Yet us as nurses are there, or as clinical officers are there. So we need to be very careful, or else we'll lose it. And it's a skill which is going to go, and it will end up being that of the volunteers. Then in future, we'll be fighting with the skill, because the volunteers will be taking it, they know it better than us. Over. So we need just to be careful. Thank you.
Thank you so much, Michael. Very important comment. Dr. Chiba.
Hello, Dr. Zimba. So I would like to make comments in addition to what Dr. Muya and Mr. Mwanza have already stated. So basically, there's no accountability system at facility level in terms of the usual stuff that work at ground level. So whether we meet our targets or not, the sense of responsibility is not there. No accountability at all. So maybe if we can create systems for accountability, we will push further. And orientations, mentorship, trainings, those things are continuously done, but you still find that things are not moving, especially in areas where we don't have COAG staff. So we keep on lagging behind because there's no accountability system at the facility level. Yeah, so that's what I wanted to add on to what has already been said.
Thank you so much. So that goes to all our facility heads, the AIT in charges, the facility in charges, the pharmacy heads, and all those to be able to just strengthen our monitoring systems and supervision. Okay, so let me just read some comments in the chat box. Helen, thank you so much for your comment that Coach suspension is still undergoing some quality checks. And so we are waiting from Zamra. And then also that there's a proposal that we strengthen data review meetings at all levels. I think this, we've come from a long way. I think we see a lot of data review meetings being done in most of these facilities. Maybe we could just try and put to practice some of the actions that we discussed during these data review meetings that we're having. Then Sana from Monza says that it can be helpful if the trained HNPs are put in right position, since task shifting was a reason for their training. Oh yes, so that's a very important contribution. Maybe we're putting people in the wrong places. So as managers, DHOs, facility heads, maybe it's something we need to look at so that as we place people, we place them in the right place so that they can do the job that they're skilled at. Then there is a comment from Edward Mwale. In some sites, AIT department is run by supported partners. There is lack of participation from MOH staff, and so they are unable to take it up when the partners withdraw their staff. Yeah, this is a common problem, and we know why it's like that. And this is why partners come in to support us. So I think as managers, perhaps we could find a way in which we can have rotations. We know there's some facilities that will always have people rotating around the HIV ART areas as to support the partners, just in case the partners withdraw. Then Luamba's comment, can you talk about dilution of the SDT? It seems there are different versions from facilities. I think we'll have a look at that to talk about the dilution of SDT3TC. And then Dr. Miti from Ndola says, I also propose that facility-based data review and goal setting be strengthened. Yeah, I think that's very important. Another comment about the cotrimoxazole suspension, that it's being currently undergoing quality check. And so Dr. Thomas has responded that dissolve 1 tablet of SDT 3CT 60/30 in 6 ml of water. And then the dose is in the guidelines. Don't rotate staff from ART clinic. Dr. Thomas doesn't think that that's a good option. Yeah, need continuation of care. Yeah, Kalingalinga ART Hub received 300 cotrimoxazole from ZAMSA. And another comment from Michael, that now that we don't have Septrin in most facilities for our exposed babies, what would be wrong to dilute Septrin tablet for 6 weeks and above? Would it be wrong? I think we'll get guidance from our pharmacy team on this one. They're saying, can we dilute the big one for the adults and break it and give it to the adults to those ones that are young, in view of absence of. Ms. Mukumbi, would you like to take that one?
Okay, I think that's an important point to raise regarding diluting the adult tablets of cotrimoxazole in the absence of suspension. First of all, obviously, ideally, the tablets are not meant for suspension, but given a choice of not giving anything and giving a tablet which has been crushed, I would say we could crush the tablet, but that's not the ideal. I think now that we've got news that ZAMSA has cotrimoxazole, the best thing would be to reach out to your provincial pharmacist or maybe the hub which is nearest to you and see how you can access the cotrimoxazole syrup.
Okay, thank you so much. I think we move on in view of time. So I'll just ask again, Mr. Chileshe, to come and take us through a SmartCare demonstration. I'm excited to see that, how this goes, so that we can learn. We'll just switch seats so that you can come and just pick it up from here.
We had 4 questions.
We can do the poll questions first. Okay. All right. So I think we'll do a poll questions, and I'll invite the network just to participate in this. We want to see how what you think is. So the first poll question is: prescribing AIT in children is based on, is it current weight, is it sex, is it height, or is it race? Prescribing AIT in children is based on, is it current weight, is it sex, height, or race? We invite the network to participate. I will give you about 30 seconds more. Okay, so thank you very much for those that have participated, but just slightly above up. Oh, I'll end the poll. So looks like everyone thinks A is the correct answer. No one thinks otherwise. So the next poll question. Feed DTG is recommended for children less than 1 month of age, weighing less than 3 kg, above 1 month of age and more than 3 kg, none of the above. What do we think is the correct answer? Is it A, less than 1 month of age, B, weighing less than 3 kg, C, above 1 month of age and more than 3 kg, or none of the above? Okay, so you have about 20 seconds more. Feel free to... When you wake up in the morning. Feel free to vote. Okay, so I am going to end the poll. Thank you very much for voting. So far, most people think C is correct. A few others, about 27%, think D. Okay, we'll see how it goes. So from here, we'll move on to sharing the demonstration on SmartCare. Is it open? Yes. Okay. Still go up here. Yeah. Okay. Thank you, Dr. Kozia. So the team had created these simple scenario questions. So this is recipient of care A. If we can also take down, if we have our docent charts nearby, we can be taken down so that all of us participate. So recipient of care A has a weight of 15 kg. The regimen is ABC3TC and Lupinava. So for the ABC3TC, the formulation is the Paediatric FDC, which is the 120 over 60 milligrams. Then you can also refer to your tables in your docent charts. So for a 15 kg child, in theory, this is how you calculate. So calculation for ABC3TC,
this child is supposed to receive 1.5 in the morning, as well as 1 tab in the evening. So 1.5 is equal to morning dose, 180 milligrams for morning dose. Then for the evening dose, which is the 3TC, will be 90 milligrams. And for the 1 tab in the evening, this child will receive 120 milligrams, which is 1 tablet, because the ABC is, the formulation is 120. That's why it still hasn't changed any. Then for the evening dose for the 3TC, this child will receive 60 milligrams. Then for the Lupinava sachet, we know that Lupinava formulation is 40 milligrams of Lupinava and Ritonava 10 milligrams, but all the same, it's a combined 50 milligrams. So when you refer to the table for the Lupinava sachets, this child will receive 5 sachets in the morning, which will be equivalent to 250 milligrams in the morning. Then in the evening, this child will receive again another 250 milligrams, because 1 sachet is equal to 50 milligrams when you combine LPVR as well as Ritonava together. So we'll now switch to SmartCare. I hope everyone has taken note of this so that we can all participate together. So now turn to SmartCare. Share. So on SmartCare, those that have SmartCare nearby or familiar with SmartCare, we have this tab that says prescription here. So now it's easy for everyone to use, the first line and just select anything here, and second line and select anything here. But for children, we need to be very precise with the prescriptions we're giving them. They're supposed to be the exact prescriptions, the exact dosages for that exact weight. So in this case, our recipient of care was 15 kgs. Then they're on ABC 3TC. So what we'll do is we'll go to this tab that says multi-regimen on top here. Then we'll click just below that square box. Then after we click, this tab will come up, and what's reading on top there says define multi-regimen. So what we'll quickly do is we'll pick any line here, preferably just any first line here. So we'll click like that. Then all these tabs here will be highlighted. We can see number 1 says AZT, number 2, 3TC, number 3 says NVP. So we'll quickly edit the number 1 to ABC since the child is on ABC. So we can click there, then select ABC. Then we can remove docents there. Then 3TC is already here. Then we can remove that and that. Then for number 3, we can change this to Lupinava as well, if you're following closely. Then the second column here says BD on number 2, 3, on number 1, 2, but number 3 says OD. So we need to click in that box there, then change it to BD as well. Then the T2 will be highlighted. So what this simply means is T1 are morning doses, then T2 are evening doses. So in this case, when you look at your dosing chart for ABC3TC, it says that this child should receive 1.5 tabs in the morning. So 1 tab is equal to 120 milligrams for ABC. So if it's 1.5 tabs, meaning the half tab is equal to how much? 60 milligrams. So the 120 plus the 60 milligrams will come to 120, which will be the morning dose of ABC, which the child will receive in the morning. Then for the T2, the child should receive 1 tablet, isn't it? So 1 tablet in the evening is 120. We hope everyone is following. For ABC alone, remember this is a fixed dose combination of ABC and 3TC, which is 120 over 60. So now coming to number 2, which is the 3TC there. So T1, remember that the child is still receiving 1.5. So what's 1.5 of 3TC, which is 60 milligrams? So that will be 90. So the formulation is 60, then half of 60 is 30. So you add 30 plus the 60 to give us the 90, which will be equivalent to the 1.5 for the morning dose. Then the evening dose, the child is receiving 1 tablet, and 1 tablet of 3TC alone is 60 milligrams. Then moving on to the Lopinava. So Lopinava sachets, we remember that 1 sachet is equal to 50 milligrams combined Lopinava and Ritonava. So if the child is receiving 5 sachets, we simply multiply 5 sachets times the 50 milligrams. So which will be 250 for the morning dose, which I've just inputted in T1. Then for T2, the child is still receiving 5 sachets, which should also be 250 milligrams here. So this is exactly how this child for 15 kg and on ABC, 3TC, and Lopinava should receive their, should be prescribed in SmartCare. So from here, then we'll quickly go to save. So when we go back to that tab, the multi-regimen tab, this is how it's going to appear. It will be strange for some other pharmacists that are not very familiar with this, but Ms. Mukumbi will come back to stress more over interpretation of how some of these regimens appear like this. So in short, from my end, how this will appear, this means ABC, the child is receiving 1.5 in the morning, and in the evening, 1 tablet. Then for 3TC, the child will receive 1.5 in the morning, then 1 tablet in the evening. Then for Lopinava, we can see that it's straightforward, 5 sachets, which is 250 in the morning and 250 in the evening. Then we can save from here. So another example now, we'll go to recipient of care sick. Okay, so I'll stop sharing this, then we'll quickly go back to scenario 2, then Ms. Mukumbi will come in. Let's stop share. Okay, yeah. So stop share and move share. So for scenario B, so this child is 12 kg for scenario B on the regimen ABC, 3TC, as well as PDTG. So formulation for ABC, 3TC is still 120 over 60 milligrams. And when we refer to the dosing chart at weight 12, so an example of a dosing chart is this one. We can quickly go to where it says between 10 and 13.9. We can see that ABC 3TC here is 120 over 60 milligrams. Then the number of tablets per dose, which they will receive, will be 2.5 tabs. Or it will be 2 tablets, sorry. It will be 2 tablets for ABC 3TC. Then plus the DTG, which is 10 milligrams here, will be 2 tablets OD. Then what will be dispensed in SmartCare? We can see the last column there is dose in milligrams. So this is exactly how it should be dispensed, prescribed in SmartCare. ABC 3TC should be 240 milligrams OD. 3TC should be 120 milligrams because it's 2 tablets, isn't it? Then DTG will be 20 milligrams OD because 1 tablet of DTG is 10 milligrams and you're given 2 tablets. That's why it's 20 milligrams OD here. So with this, let's quickly go back to SmartCare so that we get the feel of how that should be dispensed. So back to SmartCare. So we may have two options on how this can be dispensed. Number one, we can still choose to go to the multi-regimen tab and dispense it the way it was, or rather we can just still go to any of these tabs here under first line and still choose any. So for example, let's start with the multi-regimen tab so that we cover both options. So it was ABC, OD, then 3TC was also OD. Then here we select DTG, which was also OD. Then we can remove what previously inputted. So for ABC alone, remember that we're given 2 tablets of ABC alone, which will come to 240 milligrams for ABC. Then the 3TC number 2 here alone, we are also given 2 tablets of the 60 3TC alone. So 60 plus 60 will be 120. Then DTG alone, we learned that DTG formulation is 10 milligrams, and we're given 2 tablets, which will come to 20 milligrams. So this is how this may be prescribed under multi-regimen tabs. And this is how it would appear as ABC 240, 3TC 120, and DTG 20 milligrams. So this is one way. Then another way, we can simply go to the first line tabs, select any. In this case, we'll select the one that says TDF, 3TC, and DTG. So I'll select that square box right here. Okay. Then I'll select the ABC here, 3TC is already here, and DTG is already here. So just like multi-regimen tabs, I'll simply input 240 milligrams, then on the 3TC, 120 milligrams, then on the DTG, 20 milligrams. Then on the strength, milligrams, strength again here, milligrams, strength again, milligrams. On frequency, remember that we're giving it OD, so we select OD on everything. Then the mistake would usually find in some facilities, for example, the moment you highlight in this box, most clinicians are afraid to input anything manually here. They just select what has already been highlighted below here. So we should be vigilant to input exactly what is needed in this box. In this case, if your dosing chart says 240, we should input 240 instead of selecting what has already been highlighted below. That's the common mistake which most of clinicians do in these facilities. So from here, I'll simply save, then allow Ms. Mukumbi to...
Maybe we could invite questions just before you ask Ms. Mukumbi.
Okay.
So I know some of these things require hands-on, and we also know that there's some facilities that are not e-first that will depend on uploading files that have already been done. But thank you so much for paying attention. If you have any questions, please raise your hand and comment. Thank you.
Dr. Jambo.
Yes, Dr. Muya.
Somebody has raised their hand. Just check, someone has raised.
Yes, I've seen Mwila Kunda. Yes, go ahead.
Sorry. Thank you very much. A question on prescription.
Sorry, Mwila, I think the network is very bad. We can't hear you. You're breaking.
She's talking.
Sorry, we can't hear you. The connection, perhaps, maybe you could put in the chat. We'll read the chat just in a moment. So let's look at the chat.
Hi, Dr. Zambo.
Hi.
Hi, so Mando here. I can't find the button for raising my hand, so apologies for speaking.
Please go ahead. We understand.
So one of the experiences that we had as when I went to do some technical support when implementing the new PDTG was on the dosing chart itself.
Okay. So maybe you can just stop share and then put back the dosing chart. Yes, Dr. Mando.
Yeah, so I think one of the key things that I noted was that if you look at the dosing chart, for example, the one for 3 to 5.9, it says ABC3TC 1 tab and the plus DTG 0.5 tab OD. Yeah, so maybe the confusion that is coming in some of the facility staff is that they are missing that the ABC3TC is also ABC3TC 1 tab is also OD at this point. Yeah, so I know in the dose in milligrams it does show that, but I think maybe what I did was that I edited this part and just put 1 tab OD and then DTG 0.5 tab OD also, so that it helps put into context that everything is actually OD. Some of the facilities just thought of just giving the old ABC3TC as the BD dosing.
Okay.
Yeah, I did miss also part of the presentation. Apologies again. I hope we did cover also the 20 to 24.9 and this other 20 to 20.4. I hope we did mention that the strengths are different and bioavailability is different for the two.
Thank you so much, Dr. Mando, for that highlighting that important note. We haven't yet tackled the 20 to 25, and I think it will come up as we emphasize some of these scenarios. Thank you very much. Maybe we have a look at some of the comments in the chat box. I think when we're using LPV, I think we using the LPV for weight, for that weight.
It has to be swallowed whole. So I think a lot of younger children would struggle to swallow that tablet whole. That's why we prefer to use.
All right, thank you for that clarification. So we can click the same regimen. I think this is Dr. Thomas trying to describe some things. And then from Chazanga, clear and well explained presentation on dosing. Thanks very much. And then Zungairi says, please make available the dosing charts in the facility. That's important. Well explained, thanks. A great SmartCare presentation. Please show what to do when prescribing another non-ARV drug in the SmartCare alongside the AIT therapy. Thank you. Then also thank you for the presentation. I'm one of those that did not know how to use the multi-regimen option. Thank you, Danielle. And then Dr. Zimba says, for Lusaka, CIDES is helping us print the dosage charts. So that's good news for Lusaka district. We know that even other provinces, we have got partners that are printing dosing charts, Western province and Copperbelt province with our different partners. So just hang in there, they're coming. So my question is, during prescription, we are not supposed to place the preparation of the drug, not the drug dose per child example. It's difficult to understand what Mwela is trying to say. So I think we'll read it properly and get back to you, Mwela. I'll ask Ms. Mukumbi to come and just run us through the next section, the pharmacy section. We only have 15 minutes remaining. So maybe you can work within that time.
Sure.
Yeah.
Just the sharing.
Okay, so we are going to assume that our clinician has prescribed the drugs, and now the recipient of care has come to the pharmacy with their caregiver. So in SmartCare, we'll click the pharmacy and the provider. And then under the prescriptions, we'll notice that on one side, we've got prescriptions, and the other side, we have dispensations, and the two should go side by side. So we'll click on the prescription and then fill that prescription. So as we're doing that, we should also just double check that you have got the correct patient as you would do in any other interaction. So just check by name. So here we've got our 3 separate drugs. So we're going to start with ABC, and we'll click the ABC 240 milligrams OD, and we're going to select it. When you come to the drugs, you see that there's so many different preparations here, starting with the 300 milligrams, the 60. At this point, we can select any of them, bearing in mind that we've got a fixed dose combination. So once we get to this tab, we've got Abacavir on its own. We're going to search ABC. When we click ABC, we'll have different options coming up. You've got the standalone ABC, you've got ABC plus 3TC, ABC plus 3TC, ABC plus 3TC plus AZT. So we're going to pick the combination because that's what we have. And again, when we click here, you'll notice that we've got different strengths. The first one is 120/60, which is the one that we're going to dispense. We also have the 60/30, which we're no longer using, as well as the 600/300, which is the adult tablet that we're not using. So here we have to make sure we click the correct formulation. So once you've highlighted it, you're going to select it, and this will appear. So the strength will appear. And now we're going to click or enter the number of items per dose. So in this case, it's going to be the number of tablets. And like we said, 240 milligrams will be 2 tablets. So we're going to enter 2. And depending on when our client is coming back, in this case, it's after 3 months. So we're going to click 2 times 90, which will be 180. And it's always important to enter the batch number also of the drug that we're dispensing. This is very helpful because it helps us keep track of which drug we have in stock and what we're using. So we'll enter the batch number. And the refill date is just going to guide us, just to make sure we've entered the correct number of tablets. So in this case, this client is coming after 3 months. If we give 180 tablets, the refill date will be the 21st of November, which is approximately 3 months from now. So this also helps as just a cross check. So if for example, I left 10 and entered 18, the next refill date is 1st September. So that is going to prompt me to have a look at how many tablets I've dispensed. And so to remind me that I've made a mistake. And so I'll enter 180. If, for example, I enter an extra digit, I'll be prompted. If we can see there in yellow, it says the days are too high. Are you sure you still want to dispense? So this is prompting me because I've entered too many tablets, which are equivalent to 900 days of medication, which is 3 years. Okay, so the correct number of tablets is 180. So when we've done this, we're going to add. Once we've added this, we'll go back to our prescription. And alongside that dispensation is ABC 3TC, FDC, meaning fixed dose tablet, and it's indicating that I've dispensed for 90 days. So this dispensation is not yet complete because I've only dispensed 1 drug or 1 combination. So now we have to dispense our DTG as well. In this case, we'll come back to our prescription and we're going to add dispensation to prescription. So in the first instance, we were filling the prescription because we had not dispensed anything yet. In this case, we're adding to the prescription. So now that we've already given ABC and 3TC, we're going to highlight DTG. So once we highlight DTG, we're going to select. Now you notice here that it's only giving us DTG 50. We'll select 50. If we try to click the drop-down menu, there's only one strength, which is 50 milligrams. And this is because DTG 10 milligrams has not yet been added into SmartCare. So what we're going to do is we're just going to make a note. And here we're going to say DTG 10. That's just so that we know that it's 10 milligrams that we've dispensed. So again, our client is going to get 2 tablets. Remember that we're dispensing 20 milligrams. So we're going to enter 2. And under this drop-down menu, we have to enter the formulation. So here you've got caps, tabs, drops, and likewise. So because we're dispensing tablets, we enter tablets. And again, remember we're dispensing for 3 months. So 2 times 90 days will be 180. And here, it should correspond. So if we dispense tablets, 2 tablets OD, we should dispense 180 tablets. And again, it's given a prompt of the number of days duration, which is 90. And it's also given us the refill date, which is 3 months from now. And again, let's always remember to put the batch number. So this batch number in this case, because it's falling under DTG 50 milligrams, if we enter the correct batch number, it will be able to help us identify that it's actually 10 milligrams we're dispensing. So once we've done that, we're going to add. So here our dispensation is complete because we've got all 3 drugs that the child is on dispensed. We've got the ABC3TC. It's appearing on one line because it's a fixed dose combination. And the DTG is separate. It's showing 50 milligrams, but we made an entry in the notes to say it's 10 milligrams. So once we've done this, we can now do the next step and save the interaction. I'm just going to cancel this and just show you something. When the prescription comes, we shouldn't dispense the separate, there's provision for us to dispense the separate formulations, but we must always make sure that we dispense the single one. So if we were to add this, if you can see there next to the prescription is ABC alone. So in this case, we've dispensed a single formulation. So I'm sure we can see the difference between the first one where it says ABC plus 3TC, that's showing we dispensed the fixed dose. And if we make a mistake here, it will appear as a single dose, a single formulation. So I'll just delete that one. So that's the correct thing on the screen there, where you've got your ABC3TC for 90 days and your dolutegravir also for 90 days. So that's how we fill a prescription in SmartCare.
So maybe in the same, would you also like to do for the cotrimoxazole as concomitant drugs?
Okay, so there was a question about non-ARV drugs.
Non-ARV
Yeah,
drugs,
okay.
yes.
So in this case, we can go back to the original prescription here, and we add prescription or add dispensation to prescription. So in this case, we'll select any of these, or just select this one. When I come to this interface, I can search for cotrimoxazole by either typing, when you type CO, a number of options will come, and then we can pick the cotrimoxazole. Again, we've got so many formulations. This one is an IV, there's a mixture, there's a tablet, and even among the tablets, we've got different strengths, the 400 plus 80, the 100 plus 20. So we'll take it for a child weighing 12 kgs, we'll take it that they'll be on suspension. So we can select that one. And in this case, we're going to give 5 mils. So we enter 5 there. We'll enter mils. If we're giving for 90 days, we should ideally give 450 mils. But we know that that translates to 4.5 bottles, and we don't dispense half bottles. So we're either going to round up or round down. If you remember in the first presentation, Mr. Chileshe mentioned that we ask our caregivers to come with their medication or the clients. So if they come with, say, a full bottle of Septrin, then I should be able to give them 400 meals because I know that they already have something. And when I add what I'm dispensing and what they already have, it should be enough to last for 3 months. But in the case where they don't have anything, we can still give 500 meals, and we know that it will be enough to last them 3 months. So we can enter the batch number as usual, and then we can add. So the co-trimoxazole will appear here.
All right, thank you so much. Any quick questions on that interaction? I know there are a lot of chats that have been, maybe we could switch now. So any questions there on the chat?
Okay, so there's one question. What about dispensations more than 360 days? Is this new version of SmartCare allowing that? So SmartCare actually allows you to dispense more. It just prompts you, just in case you've accidentally pressed a number which is more than 180 days. So the ideal maximum is 180 days, but it will allow you, but sometimes when saving the date, you may have problems. So I think that one is more of an IT question. I'm not that technical with SmartCare, but on the dispensing side, you can dispense. But when it comes to saving the date, I think there might be a problem there. So I don't know if there's a more technical person who can answer that question.
So my question during the prescription, are we supposed to place the preparation of the drug, not the drug dose per child? Example, be the adult doses don't double in prescription. It's difficult to understand. I think it's well, I had trouble with the network, and I think it's difficult to understand the comment. Let's go down and get some more comments. What is the dose under the DTG? I think that was mentioned that currently there's just 50.
Yeah.
I think it will be updated as we go on. Then there is need to correct the dose on PIT. Yes, definitely.
Yes.
Then Precious, you have a very valid point just to assure you that it is being done. Yes. I think that's all on the comments. Are there any hands? Anyone would like to ask a question on what we've discussed so far? I hope it's been a very useful session, and we're learning one or two things. I think one of the issues that we found out when we were interacting with our staff on the ground is that some of them were just doing the dispensation part and not doing the clinical prescription, the prescribing part. And so you find that you're trying to get some information, it's not coming out. Yeah, I've seen a hand. Dr. Delira, would you like to unmute yourself and make a comment? Dr. Zachary, I've seen your hand. Let's just switch. Okay. Thank you so much, Ms. Mukumbi. That was very, very good. I don't know, Dr. Zachary might be struggling with to unmute yourself. Can you help with unmuting? Unless there's a problem. Okay, so. Okay, yes, Dr. Zachary, would you like to make a comment?
It is just a connection for me.
Unfortunately, we're not able to hear you. Sorry. Okay, all right. Okay, so I think we just want to wrap up this presentation. Mr. Chileshe, maybe you can just speak to this summary points.
Okay, so on the summary points, number one, we've seen a number of gaps that have been identified all throughout the care of Cascade, and there is need that healthcare workers at facility level, district level, as well as PHO The TA partners as UTH, we all have the same goal as the facilities we're visiting. What we find are the gaps, are our gaps. What their achievements are also our achievements. And when we go around in these facilities, we mostly do emphasize that it's not fault finding per se, that we're there to police them to. So let's keep in mind that this is a collaborative relationship that we've created with all the facilities that we visit, and we work towards achieving and filling up all the gaps together as the TA partner. Then secondly, correct, so we also, among the summary points, we also did then the correct of entering SmartCare prescriptions during the demonstration, which Ms. Mukumbi had done. Then also the last point, she had also demonstrated correctly on how dispensations are supposed to be done for non-ARV drugs, as well as ARV drugs as well. So I think the call to action is reports are usually sent to the districts and healthcare. And if some of those things are not clear, it's important that we all work together in order to ensure that those gaps are filled in, both as implementing partners in all the different districts, as well as provinces and TA partners as well. Thank you so much.
Thank you so much, Mr. Chileshe. And I think Dr. Zachary wanted to say that, just wanted to clarify for the network, given that TTG dose 10 milligram has to be written in the notes section, does this dosage also get written again in the dosage line of the form? Or it's okay to just write once the dosage in the dosage line? I don't know if you understand that. I think just a clarification on how to document the DTG-10.
Okay, so maybe I should quickly mention that this is just an interim measure as we're waiting for the 10 milligrams to be entered into SmartCare. So this is just for those sites that have received the 10 milligrams and have started using it. But very soon, in the next few weeks, I think SmartCare will be updated and we'll have the 10 milligrams. So the prescription will read 10 milligrams, but the dispensation for now will read 50 milligrams. I hope that's clear.
All right, I think that's clear. Thank you so much. Dr. Muya, would you like to make some comments? Dr. Mundali, any remarks as we wrap up this afternoon session?
So, Dr. Jambo, from us, just want to thank Mr. Chileshe, Mr. Mukumbi, and the entire team for putting up this presentation. I hope it has been of use to the network. We appreciate our partners that we work with in the 4 provinces that we are supporting. We want to say to them, thank you. Despite us just showing the gaps, just that there was little time, there are a lot of good things that are happening as well. But I think when good things are happening, they continue, but just to, we highlighted gaps so that we can improve on what we are doing. Otherwise, they shouldn't feel that we are there just to identify gaps. No, no, no. A lot of good things are happening, but we just wanted to highlight where areas of improvement, and we really appreciate them. And let's keep working together. Thank you very much. Over to you, Dr. Jambo.
Thank you very much, Dr. Muya. Dr. Muntali, I don't know whether you're on the call. You'd like to make some comments as well. I think maybe may have dropped off. Dr. Muntali is our pediatric HIV coordinator. Otherwise, thank you very much. This has been very helpful, and I think as an HIV program, we're very happy that the UTH hub team was able to come back and give us this feedback. And we would like to see the HIV program for the children really gain milestones, as we are slightly lagging behind from the adult program. And so with everybody on the call, thank you for joining in. Thank you for your comments, and thank you for your remarks. We appreciate, and we will see you next week as we have our provincial-led ECHO. And then also I would like to announce the network that on Thursday, we have the Southern Africa Regional ECHO session. And I would like all healthcare workers and all facilities to participate. A link will be shared we'll be talking about vaccines and the variants of concerns and how the two are working and how that we can be able to mitigate the COVID that is happening right now. And so we look out for your availability on the call. Please join us, and I would like you to be part of this, as we would like to see many healthcare workers also improving in taking up the vaccines. So far, we're at 40% as healthcare workers. We would like to have as many healthcare workers vaccinated and get to be protected as we are high risk individuals. So that being said, thank you very much, everyone. We'll see you next week. Have a good day.